had a ferritin blood draw done, told it's fine, and yet you struggle with those characteristic symptoms of iron deficiency like low energy, weird cravings, restless legs, and brittle skin, hair, and nails? A single ferritin number doesn't tell the whole story. In this video, I explain every part of a full iron panel, including serum iron, ferritin, TIBC, and percentage saturation, why looking at the full panel is more important and more valuable than a single ferritin marker. We discuss patterns clinicians use to diagnose various forms of iron deficiency, anemia of inflammation or chronic disease, copper retinol-related iron problems, B12 or folate deficiencies, and iron overload, and what these mean for pain, inflammation, thyroid health, and fertility. Get out your most recent iron panel and let's dive in. If you haven't already, please give this video a like, share it with a friend, and hit that subscribe button. So why does iron matter with endometriosis, period? Why care about having perfectly optimal iron levels? People with endometriosis have higher rates of iron deficiency, both from heavier bleeding and from higher overall inflammation. This is not great because low iron can increase pain sensitivity and increase the amount of inflammation body-wide. Conversely, iron can also accumulate in endometriosis lesions and body-wide and drive more oxidative stress. That means that both too little and too much iron can be harmful and drive inflammation and pain. We also know that iron is involved in oxygenation, and it's very hard to maintain optimal thyroid function, for example, with low levels of iron. What does a full iron panel include? Strictly speaking about iron, a full panel includes serum iron, TIBC, ferritin, and percentage saturation. But markers like hemoglobin and MCV found on a complete blood count can also provide insight into your iron status. So what do each of these markers indicate? Serum ferritin is a marker of iron storage, but it also acts as an acute phase reactant or marker of inflammation. We will discuss what pattern to look for to suggest high inflammation shortly. Serum iron is a marker of circulating iron bound to transferrin. Transferrin is a protein in the blood that transports and regulates iron in the body. TIBC, which stands for total iron binding capacity, or serum transferrin, is a marker of the maximum amount of iron your blood proteins can bind. This marker is usually higher in iron deficiency and low in iron overload. Transferrin saturation is a marker of how much the iron-carrying protein transferrin is actually bound with iron. MCV, which stands for mean corpuscular volume, is a marker of red blood cell size. If MCV is low, so it falls under 82, this would indicate microcytic anemia, which is typical with iron deficiency. If MCV is high, so typically above 89.9, this can indicate macrocytic anemia, often due to B12 or folate deficiency. Hemoglobin is an iron-containing protein in red blood cells that carries oxygen to various tissues of the body. Low hemoglobin can be a reflection of low iron because hemoglobin requires iron. However, it does not explain the type of deficiency. As a young female, you want your hemoglobin to fall between 13.5 and 14.5, or 135 and 145 grams per liter. So now let's talk about a few interesting iron patterns and what they can mean. Pattern number 1 is the classic iron deficiency anemia pattern. This pattern is characterized by a low ferritin, so under 30 nanograms per mil, low serum iron, so typically under 50 micrograms per deciliter or under 8.96 umol per liter, a high total iron binding capacity over 350, and a low percentage saturation, typically under 20%. You might also see iron deficiency anemia presented in low hemoglobin or low MCV, but these markers are not enough to establish a classic iron deficiency anemia. You have to look at the iron panel. With this pattern, you will want to be assessing your iron intake relative to iron losses in blood. Consider heavy menses or surgical losses. Consider how well you absorb nutrition, and if you present with any symptoms of small intestinal bacterial overgrowth or parasitic infection like anal itching, progressively worsening bloat throughout the day, constipation, diarrhea, or both, undigested food in the stool, floating stools, or abnormal burping, belching, or heartburn. You'll definitely want to consider the latter if you are either supplementing with iron or you know that you're getting a reasonable amount of iron in the diet. And just as a side note, 18 milligrams is what you need to be getting in per day as a young, healthy female. Up to the age of 50, your needs do increase a little bit in pregnancy. And so if you're hitting that or above consistently every single day and your absorption seems to be the problem, that's when you'll start to consider the latter, like the SIBO and the parasitic infection. So let's talk about what to do next. If you present with symptoms of bacterial overgrowth or a parasite, one of your first considerations might be to consider some testing. This might include a stool test for Helicobacter pylori or a parasite, or a breath test for small intestinal bacterial overgrowth. So see my video on SIBO to learn more. I did do a comprehensive video on that topic. If you are not presenting with these symptoms or you're not in a position to test for these things, you will definitely want to prioritize increasing iron sources in the diet. Preferably, you try to get in 18 plus milligrams of iron from diet daily, more if you're severely deficient, before supplementation. As depending on the root cause of the deficiency, supplemental iron may make symptoms worse. It's notorious for iron to cause constipation or GI discomfort. The best dietary sources of iron include oysters, beef, lamb, organ meats, clams, mussels, dark meat chicken and turkey, sardines, and tuna. You can also get iron from cooked lentils, tofu, black beans, chickpeas, dark chocolate, and seeds, but these sources need to be strategically paired to support absorption. If you're at a point where you absolutely require supplementation, consider lower dose ferritiform iron at doses roughly between 13 milligrams and 27 milligrams daily and in divided doses. All right, pattern number 2 is anemia of chronic disease or anemia of chronic inflammation, and this is that inflammatory pattern that I alluded to earlier in the video. So this pattern is characterized by high ferritin, typically well over 80, low serum iron under 50 micrograms per deciliter or under 8.96 umol per liter, lower normal TIBC, and low percentage saturation under 20%. With this pattern, chronic inflammation, chronic infections, malignancies, or critical illness cause the release of inflammatory chemicals interleukin-6, interleukin-1, and tumor necrosis factor alpha. The release of these chemicals signal hepcidin production in the liver. Hepcidin then binds ferroportin on various cells to prevent it from remaining in the blood and shuttles it to iron storage. This prevents access of pathogens, bacteria, and viruses to iron in the blood. So what to do next if you're satisfying the criteria for this pattern? It might be impossible or near impossible, but try to understand the source of inflammation. The solution to solving anemia of chronic inflammation is to reduce the inflammation and to normalize iron levels. Diet and lifestyle interventions like fruit and vegetable juices to flood the bloodstream with antioxidants, a Mediterranean-style diet, anti-inflammatory supplements, exercise, good sleep, meditation, and nervous system supporting therapies are all fantastic things to consider for reducing inflammation. Keep in mind, you might have to also look internally for sources of inflammation. It's also possible that the endo could be causing you to just be so inflamed that you're presenting with this pattern. So key focus on inflammation reduction in any way that you have the capacity to do so. Pattern number 3 is poor iron to ferritin conversion, which is very common with low copper or low retinol affecting iron handling. So this pattern is characterized by a low ferritin or low relative to the available iron in the blood, low or normal serum iron between 50 and 100 micrograms per deciliter or 8.96 to 17.91 umol per liter, normal TIBC between 250 and 350, and normal percentage saturation between 20 and 35%. So how to interpret this pattern? Copper is essential for ceruloplasmin production, which is a copper-carrying protein made in the liver. It's also essential to peroxidase activity. So this helps convert iron from cells from the ferrous form to the ferric iron form, which is then loaded into ferritin stores. For this reason, if copper is low, it can produce a copper deficiency anemia via abnormal iron handling. So what role does retinol play? Retinol is the active form of vitamin A found in eggs, full-fat dairy, organ meats, and cod liver oil. Retinol is needed for hepatic or liver synthesis of ceruloplasmin. Retinol also supports the use and movement of copper throughout the body. For this reason, copper can't function properly without adequate retinol. So what to do next if you suspect this pattern? Consider checking copper ceruloplasmin, and or vitamin A status in the blood. Also correct deficiencies by integrating more copper and retinol sources in the diet. My favorite copper-rich combo is 1 ounce of dark chocolate paired with 3 tablespoons of sunflower seeds or cashews. This combination will give you 100% of what you need for the day for copper. Okay, pattern number 4 is macrocytic anemia, typically driven by low B12 and or low folate. This pattern is characterized by mostly normal ferritin, serum iron, TIBC, and normal percentage saturation, but the mean corpuscular volume marker may be elevated well above 89.9, and hemoglobin may be low under 13.5. There are a few causes for this pattern, one of which is vitamin B12 deficiency or folate deficiency. Other reasons include excessive alcohol intake, liver concerns, or hypothyroidism as secondary causes. It's important to note that the solution to this pattern is not more iron supplementation, but rather correcting cofactor deficiencies, and most often those are the B12 and folate deficiencies. So what to do next if you suspect this pattern? Check your B12 and folate levels in the blood. If levels are low, so under 600 pg per mil or under 442 pmol per liter for B12, or under 20 nanograms per mil or under 45.3 nanomoles per liter for folate, consider supplementing with an active B complex or integrate more dietary sources of both. The best dietary sources of B12 include clams, liver, trout, salmon, sardines, tuna, beef, chicken, eggs, and milk. The best dietary sources of folate include beef, liver, lentils, chickpeas, black beans, spinach, asparagus, and broccoli. Okay, pattern number 5 is the iron overload high ferritin pattern. So this pattern is characterized by high ferritin, high serum iron, low TIBC, and a high percentage saturation, well over 35%. This pattern shows iron overload caused either by hereditary hemochromatosis or local iron accumulation via diet or supplementation. In endometriosis, iron can accumulate in lesions in peritoneal fluid, leading to local oxidative stress and inflammation. This is a separate problem from systemic iron overload, but important because free iron drives reactive oxygen species and pain as well. This is often why I heavily stress that it's not necessarily neutral to just supplement iron for the sake of supplementing iron. You should only ever be taking iron supplements in response to blood labs indicating a true deficiency. So what to do if you suspect genetic hematomacrosis? So you can test for the HFE gene. The C282Y mutation is the most common mutation and poses the highest risk for iron overload. If this applies, you might be required to donate blood or bloodlet to keep levels normal. This is typically the only treatment for genetic hematomacrosis. As needed, you can also request a referral to a hematologist or a gastroenterologist. If you are in iron overload due to a recent transfusion or high dose supplementation, the first step would be to stop supplementation of iron. Also, be mindful of cast iron cooking pans or utensils, powdered or blended products that might contain iron, and be mindful of your overall dietary intake of iron. If it's not genetic hematomacrosis and you're losing blood through menstruation, eventually the levels will reduce. All right, so to conclude, because ferritin rises with inflammation, a normal ferritin or a high normal ferritin doesn't always exclude iron deficiency, and a high iron might indicate more than just high or good iron storage. Likewise, a low hemoglobin with normal ferritin needs context. That's why a full panel, including ferritin, serum iron, TIBC, and percentage saturation, plus a CBC and CRP, if inflammation is suspected, is the best approach. Additionally, low iron can worsen pain perception, fatigue, and thyroid function, and can reduce fertility potential because iron is extremely important for egg quality and oxygenation. Conversely, iron overload or excess free iron in tissues can boost oxidative stress and potentially impair the pelvic environment, generating a lot of inflammation there. And if you have a fertility specific goal, that can also contribute to a lot of inflammation and oxidative stress local to the reproductive organs. Both extremes matter for egg quality and fertility planning, so the goal is balanced iron status, not simply more iron. And as I've alluded to already, iron status also affects thyroid function. Systemic reviews connect low iron ferritin with impaired thyroid hormone synthesis or altered thyroid function tests, which is relevant since many people with endometriosis report thyroid symptoms And we know that hypothyroidism is associated with more severe forms of endo and more unpleasant symptoms of endometriosis. I just want to end off with some practical takeaways and a suggested testing checklist. If you have endometriosis and symptoms like fatigue, poor exercise tolerance, hair loss, low mood, and worsening pain, this is my suggested testing checklist. A CBC, so a complete blood count, which includes an MCV, as well as a hemoglobin, ferritin, serum iron, total iron binding capacity, and transferrin saturation. CRP, especially if you suspect that inflammation is part of your symptom picture, B12 and folate, and also consider copper, ceruloplasmin, or vitamin A labs. If you found this video helpful, like and subscribe, and I'll see you in the next one.